discussion을 진행해 주십시오. Our next speaker is Dr. Randolph Wong from China's University in Hong Kong. He's a cardiothoracic surgeon. He has training in Hong Kong. Yeah, please start.
Thank you, Chairman. I would like to thank Dr. Cho and Dr. Kim for their kind invitation for me to have a chance to present our humble experience of a hybrid aortic intervention, the team approach. So this is how Prince of Wales Hospital looked like 30 years ago, and since 2010 we have this whole new building, a trauma center and the main block, and we situated at the 7th floor, and our hybrid operating room situated at the 5th floor. So today, I'm going to briefly talk about the establishment of our hybrid theater system and setup, and also we will allude to the Aortic MDT and type of the procedure that we are currently doing, and finally summing up with our experience. So for hybrid theater, worldwide, single brand Siemens, there are more than 600 installations over 30 countries worldwide. And last year, year 2012 alone, in Asia Pacific, there's more than 51 installations. So you could see the trend. There had to be a reason behind the trend for having such a massive increase in the number. In fact, in the early 1970s, people started to combine procedure, the MICAP and the PCI, which claimed to be the best combination of the both world, cardiologist and cardiac surgeon. And with that in mind, and in the early 90s and the 2000s, there are combination hybrid procedure combining the vascular intervention of the abdominal aorta and CABG. So people start to think that we need to have a common platform for various cardiovascular specialty to work together and perform better. And this is the shifting of the paradigm from the old one, which we work independently, and now we work more hand in hand and as a team. And with that platform, the hybrid operating room platform, we aim to reduce the unnecessary transport from the operating room to the interventional suite, and we have the better operating room set up. We basically combine the best of the two worlds. So it will improve the clinical workflow. It allows to perform more complex and high-risk operation for sicker patients with potentially less complication and faster recovery. This is our setup. This is the Siemens floor mount monoplanar system, and it has a robotic arm which allows the 8 different dimensional movement of the C-arm. And it is our control room, and this hybrid operating room was established in 2012. And what's more is in our hybrid room, we also have the endo lab from stores that allow at the moment we are combining an open surgery with percutaneous treatment, but in the future, potentially we can combine a minimal invasive through the endoscopic way together with the percutaneous. So it opened up possibility. As I mentioned, we use the floor mount system, the artificial system, instead of the ceiling mount, that we try to fit in the requirement of our infection control with this HEPA filter, and we allow the laminar flow at the operating field. So it has different packing and standby position, which when we are doing our operation, the C-arm is well away from the operating field, and I will show you later a picture later. So we routinely monitor the patient with BIS and also the cerebral oximetry, so to monitor the cerebral function intraoperatively. And this is our access of choice. I'm sure it's familiar to our cardiologists, the ProClose device, to really further decrease and minimize the excess trauma to our patient. And we're routinely using the ProClose device for TIVA cases. And you will see the end result is very nice. And also, we try at the moment measure the hemodynamic in the true length false lumen by a catheter placed in the false lumen and true lumen at various levels before and after stenting. We don't know, we don't have an answer yet, but we would anticipate change of the false lumen pressure after stenting. But so far, for the cases that we gather, the change is not as much as expected. So this is the typical setup. Then before, this is the case of total arch replacement elephant trunk followed by TIVA. During the procedure, before we proceed to the second stage, this is the intraoperative 3D TE that we monitor the patient cardiac function upon coming off bypass. This is where we place the cardiac bypass machine, and anesthetic comes over here. And the C-arm is in a standby position, so it's well away from the operating field. And to us, to surgeon, all the setup in a hybrid theater is brand new. So we need simple stepwise approach, teaching us how to manage the C-arm and also the RTC ecosystem. The company is quite good. They can give you a protocol stepwise base how to set the different angle and how to set the roadmap, and is quite user-friendly. So with that in mind, I'm going to briefly tell you about the TIVA program here in Hong Kong, Prince of Wales Hospital. So the program actually started in 2006. It's not a very old program. The first group of surgeons were trained in Europe, but however, at that time the stent is completely paid by the patient. So we had very slow takeoff because of the patient pay issue. But in 2010, the government decided to pay for all the stents. So that's why the numbers significantly increased after 2010. And we decided, with that in mind, we decided to develop a hybrid theater, and it was established in 2012. And we also established our aortic multidisciplinary team since the late 2012, and we started to use our hybrid theater in 2013. So this is a typical aortic MDT meeting, and we try to offer a total aortic solution, of which a vascular surgeon, intervention radiologist, anesthetist, perfusionist, and cardiac surgeon, and sometimes cardiologists are in the meeting that we discuss the preoperative imaging to see which patient will benefit from endovascular treatment and which patient will benefit from open surgery. We will perform the surgery together, and we will review the imaging after the procedure and see whether we need to deal with the expanding false lumen, the endo-lead, etc., etc. This is a typical preoperative planning MDT. She is a vascular surgeon trained in Perth that now discussing a tailor-made fenestrated abdominal EVA graft before the procedure. So in the MDT, we would discuss the indication of intervention. In contrary to have a fixed criteria of who should receive open and who should receive endovascular, we discuss individual cases, every individual cases, to see a panel approach, to see which treatment should benefit the most the patient. And we will overview the patient vascular anatomy to design the landing zone, the confirmation of the landing zone, the distal landing zone, and the access vessel, etc., etc. So the perfusionists and anesthetists are also involved in case of we need a hybrid procedure, we need total arch debranching, we need antepercerebral perfusion. We will discuss the issue in terms of operative planning. And we will discuss type of bypasses and the stent graft that we use. Since the stent graft, individual stent graft are a little bit different in design, and they may benefit different individual patients. And from last year onward, we also have some tailor-made stent. So the extra anatomical bypass, as already alluded by Dr. Song just now, it depends on the zone of landing, and we'll routinely perform carotid, axillary, depends on the zone of landing. And the consideration we will take into account the competency and the completeness of the circuit of Willis, and also the dominancy of the vertebral artery in determination whether we need to reimplant the Palavian artery. So this is just a landing zone, the slide showing the landing zone. In contrary to what Dr. Zong experiences, what we routinely do is a carotid axillary bypass. This is our preferred approach. And in patient with needed zone 1 landing with non-dominant left vertebral artery, we will just do carotid bypass. And if they have the dominant left vertebral artery, we will do carotid axillary bypass. And the benefit of having an MDT is we can combine the different little subsets of skills of individual specialty. And we published this case report in Annals of Thoracic Surgery, a case of rupture diverticulum of Comeral. And we perform a bilateral carotid exterior bypass, and also we use the Amplatzer device to occlude and embolize the aberrant vessel. So this is the end result. We show the aneurysms nicely excluded. And we will perform aortic debranching surgery accordingly for zone 0 landing. And if we need to reimplant subclavian artery, we will not hesitate to do a total arch debranching followed by a stent. So this is an example of a patient with ascending and arch aneurysm that we perform, and also a chronic dissection involving the distal arch and also abdominal aorta that we perform total arch replacement and elephant trunk procedure. And this is the graft that we prefer in patients with mega descending and thoracic aorta. Is the Sienna graft, which have a very nice swing cuff to stitch on, and it can accommodate and make mega and exceptionally big descending thoracic aorta. And we reported this in the Annals of Cardiothoracic Surgery, and the video is available online, and you're welcome to have a look. So the potential future development in this technique would be a Foraflex technique, but currently it's not available in Hong Kong, and potentially available in Hong Kong in mid-2014. And it will potentially provide a single stage, one fixed solution to ascending arch and descending problem. So we are anticipating this product. So in patients with special consideration and with very small femoral access, short iliac, calcified iliac, and this patient is BMI of 35. So it's a short and obese lady. She's quite old and have multiple comorbidity, which preclude conventional open surgery. So we decided to use an isolated, prolonged, elongated graft. So we perform minute-otomy, we side-by the ascending aorta, we connect and anastomose a 10 millimeter graft, pull it all the way down to the femoral access, so we make it no difference. So we fix it with an adhesive film so that when we are doing the wiring, it won't move along. And we snare it with 2 double snare to an 8 French shift. And then we perform the stenting. This is a short video. So with this approach, now the surgeon here is pinching on the limb. The beauty of this technique is if you have a short graft, your wire is just all over the place, and your hand will be shown at the X-ray machine. But pulling it out to the femoral level, just make it just like the conventional method, and the wiring thing is more handy. So, and since we open up the chest, we use cell saver. So this tiny blood loss doesn't make a big difference. So the snaring sometimes could make it difficult to advance, but it's not too difficult. I mean, you can just advance the stent without a big problem. So we will see the advancement of the stent system. Sorry for the quality of the video, but I think you can see now it's slowly advancing to the desired area. And in this antegrade type of stenting, we look at the distal, in contrary to the conventional proximal landing, it's a reverse one. So we will see, in this case, we intended to land on the subclavian artery. So once it's in place, we anti-clockwise release of this stent. This is a Medtronic stent, since it didn't have a proximal or distal specific design. As in Coke, it has a bar and the standard stent at the proximal landing. And in relay, it is more complex in terms of deploying the stent. So we choose a Medtronic, which has a similar proximal distal design, and it can allow a quick and easy deployment. So this is the antegrade. You rarely see this kind of picture, the wire coming from the ascending aorta, and this is after result. So in our experience, as I told you, in 2010 on afterward, we are doing roughly around 20 to 30 cases a year. And in 2012, since we are establishing our hybrid theater, so in fact the number suddenly dropped. So a lot of our patients are type B aortic dissection with complication. So we have done total 85 TLAS cases, The procedure-related depth is 2.5%. We have one acute retrograde aortic dissection and one rupture false lumen at the distant, non-related to the operative field. The 30-day mortality is 6.4%, and total debranching numbers is 7, extra anatomical bypass of head and neck vessel 38. Re-expiration for bleeding, there are 2 cases, minor stroke, 4 cases. They don't have significant stroke afterward. And paraplegia 3, we do not perform routine preoperatively CSF drainage, but we only perform CSF drainage once if the patient have any sign of paraplegia, and keep it for 72 hours. So there are 4 type 1 endoleak with proximal landing zone that necessitate an extension, proximal extension of the landing zone. And there are 8 deaths after 30 days, 1 aortic related death from aortic esophageal fistula, and 7 non-aortic related deaths. The overall survival at 5 years is 81%. But I have to share with you one important thing is we also do, when we are doing type aortic dissection, during the circulatory arrest, if we can't fix the arch problem, we will also deploy a Jamboli stent, which was designed to treat this. So good judgment comes from